Thank you. So I guess I get to be the one who wakes up early every morning. It's okay. It's good. Uh, so we're going to talk again, start the day with liver disease and talk about something really, really basic. Yesterday was sort of very avant-garde, talking about hepatitis C and all the latest treatments. We're going to dial it way back today and talk about really the fundamentals of how you evaluate liver disease in your clinics. Some of it will be very basic, and I apologize up front if I'm insulting anybody's knowledge base or intelligence by talking about some very simple stuff. But I think it's good to refresh one's, things that we do every day, to refresh the basis for why we do what we do from time to time. So what I want to cover today are the markers of liver injury, make a distinction between liver injury and assessment of liver function, and then synthesize how we use these tests of liver injury and liver function to evaluate liver disease in our clinics. So this is really the core of how any liver disease is evaluated. So liver injury markers are markers that are elevated in blood when the liver is injured. And they do not tell us anything about the function of the liver. They tell us that something is injuring or bothering the liver. And the classic ones are the AST, the ALT, alkaline phosphatase, and the gamma GT. So the AST is a mitochondrial enzyme in the liver. It's also present in the heart and muscle, so it's not absolutely specific. Typically, when the liver is injured, the AST and the ALT go up, but for most types of liver injury, the AST is lower than the ALT. So that can be sometimes a helpful clue, as I'll go through with you. And when the AST increases, it generally involves a disease that's affecting the liver mitochondria, or sometimes when you progress to cirrhosis, the pattern of liver enzyme abnormality shifts, and the AST becomes higher than the ALT. It's typically measured in your lab by a colorimetric assay, and the relevance of that, again, will become clear momentarily. The ALT, on the other hand, lives in the cytosol. It is more liver-specific, and it is a marker of liver parenchymal injury. So when I say parenchymal, what I mean are that the hepatocytes themselves are the target of injury, because the liver has different types of cells. You have hepatocytes, you have biliary cells, you have endothelial cells. When you principally attack the hepatocytes and kill the hepatocytes, the ALT tends to go up. Now, this is a very, very old slide from 1978, from the early days of when liver enzymes were established, and it shows that across a spectrum of disease, there is an elevation of liver enzyme, and this really set the basis for how we evaluate liver disease and why we use liver enzymes as sort of a routine way of assessing the liver health. And we can see that there is a tremendous variability, but there are certain diseases where the liver enzymes are higher than others. Now, one of the problems that we have now discovered is that there is substantial lab-to-lab variability. So there are two sources of variability in assessing liver enzymes. One is what we consider normal. So most of the normals that your labs have set were based on individuals who were self-reported normal individuals 30, 40 years ago. And they had their blood work done, and whatever was the mean and two standard deviations, they made a cutoff, and they said, if it's below this, you're okay. If it's above this, then you're abnormal. But we now know that 30, 40 years ago, we did not know anything about hepatitis C. We didn't know a lot about a lot of these diseases that we currently know about. And so many of those people actually did have liver disease, and the true normal is probably a little bit lower. The second problem with the normal is based on this colorimetric assay that I was talking about. Some of these use pyridoxine to enhance the reaction to generate the color faster. So the labs that use kits or reagents that involve pyridoxine, typically because of the faster generation of color, you get a higher reading than if the methods that do not use this. So it's just a methodological thing. But this study shows across a multitude of centers, there is significant variability in the range of, given the same sample sent to 8 different labs, there's a certain degree of variability. And this difference based on the method is about 10 to 20 units. So if your liver enzymes were very high, 400 for example, it's probably not a big deal because between labs it would vary from 400 to 410, 420. It doesn't really alter the way you think about the enzymes. But if you think about somebody who's got normal, and a liver enzyme of 35 or 40, a difference of 10 may make a difference in terms of whether you call it normal or abnormal. So just, you need to be aware of what the normal for your lab is. And so this is what I was saying, that the impact of this laboratory variability is greatest when you have low levels of liver enzymes, not when you have high levels of liver enzyme. The third enzyme we use is alkaline phosphatase, which is a canalicular enzyme. So you have hepatocytes, and in between hepatocytes is a biliary canaliculus. And that's where the bile that is made in the hepatocyte goes into the biliary canaliculus. So it's a canalicular enzyme, but it's also present in the intestine, placenta, kidneys, and bone. And there is a normal physiologic increase in adolescence when you've got a lot of bone growth, and also in pregnancy due to placental alkaline phosphatase. But typically, if you have a cholestatic disorder, a problem where the primary problem is the flow of bile out of the liver, the alkaline phosphatase will be elevated. GGT is a very misunderstood enzyme. It is widely present. So the common misconception is it's a liver-specific enzyme. It is not. It is widely present. In fact, the brain and kidney has a ton of GGT in it. But it's also present in the liver and is very, very uber-sensitive to the most minor thing that happens to the liver, the GGT tends to go up. So it's relatively non-specific. And it turns out that GGT may actually be a better marker of oxidative stress. So one of the main antioxidants in our body is glutathione, that's shown on the left. And when you use up your glutathione to respond to oxidative stress, you have to regenerate glutathione. And that involves breaking down extracellular glutathione into glutamate and cysteine, which is then individually taken up by cells and then reconverted into glutathione. And this involves GGT. And so activation of GGT occurs when you reduce your glutathione stores because of oxidative stress and using up all your glutathione, and when you have a need to regenerate glutathione. So GGT is a very good marker of oxidative stress. And oxidative stress actually is now strongly linked to vascular inflammation, and vascular inflammation is also an important event in driving the risk of getting the unstable plaque and actually having a coronary event. And here's data showing the impact of GGT. If you look at all the GGTs and break it into quartiles, particularly in people less than 70 years of age, shown in the blue bars, what you see is that there's a stepwise increase in cardiovascular risk with increasing GGT. Now, when you look at liver enzymes, ALT, which is the most common liver enzyme that we look at in the population, about 8% of the general US population has elevated liver enzymes for which there is no apparent cause. So after looking for hepatitis C and all the usual stuff, there are about 8% of people who have elevated liver enzymes. And it has now been shown that Those who have elevated liver enzymes, most of this is accounted for fatty liver disease, which we'll talk about in a second. But having elevated liver enzyme, not only in the US, but there's very good data from Asia as well, is a biomarker of high all-cause mortality as well as liver-related mortality. And particularly, there's almost a 9 to 10-fold increase in liver-related mortality, even if you have very modest levels of liver enzyme elevation. So a common mistake is to say, well, your liver enzyme's only marginally elevated, don't worry about it, it doesn't mean anything. No, it does actually mean something. It is important, particularly if it is persistent, it is important to pay attention to it. So to summarize what we just went through, AST and ALT, which is also known as SGOT and SGPT for some of us who are a little bit older, these are principal markers of parenchymal liver injury and necrosis. Alkaline phosphatase is a marker of cholestatic liver injury. GGT is a marker of oxidative stress. And liver enzymes are both markers of general health and all-cause, as well as liver-related outcomes. So then we've talked about injury. None of this tells us anything about how well the liver is functioning. So how do we assess liver function? Well, the first test that we use for liver function is the bilirubin. And bilirubin, all of us know, comes from breakdown of hemoglobin via biliverdin. Bilirubin is very hydrophobic. It doesn't like water at all. And so it is carried by albumin in circulation and in the form of unconjugated bilirubin. Once it is taken up by the hepatocyte, you attach a glucuronide to it and you turn it into conjugated bilirubin, which is water-soluble. The water-soluble conjugated bilirubin is secreted through the canaliculus, and that's the canaliculus in the middle, 2 hepatocytes on either side, and so you get your conjugated bilirubin in the biliary canaliculus from where it finds its way through the biliary tree into the intestine, where bacteria convert it into sterco and urobilinogen. Some of the urobilinogen can be reabsorbed and come out in urine. So what happens is that when you get liver injury and your liver function is compromised, because this is a function of the liver to convert bilirubin into conjugated bilirubin and excrete it. So it's the excretory function of the liver. Where you get a defect is at the level of canalicular excretion, because that's the rate-limiting step. So when you get any kind of liver injury, you take up bilirubin, you conjugate it, but you can't get the conjugated bilirubin into the biliary canaliculus. So it regurgitates back into the circulation, and from there, because it's water-soluble, gets filtered and comes out in urine. And so you get hyperbilirubinemia and dark urine from the bilirubin. So there are 2 types of hyperbilirubinemia that we see in clinical practice: unconjugated, which is typically due to hemolysis or something called Gilbert syndrome. And then you have conjugated bilirubin, which is due to liver injury, which could be either parenchymal or cholestatic, because regardless of the type of injury, the rate-limiting step is the canalicular secretion, and you accumulate conjugated bilirubin. So the clinical pearl is that if you see somebody who's yellow in your office, somebody who's jaundiced, a good question to ask is, what is the color of your urine? If they say, my urine looks fine, then you know they have got unconjugated, they got a hemolytic process. You don't need to worry that much about their liver, because unconjugated bilirubin is not water-soluble. It's tightly bound to albumin. It does not get filtered by the kidneys, so none of it ends up in the urine. But if they say, my urine's looking like Coca-Cola, then you know that you're dealing with a liver injury. It's either parenchymal or cholestatic. It's conjugated bilirubinemia. The other test that we use is the prothrombin time. And there are, again, a lot of misconceptions about how to interpret and what the implications of this test are. So the prothrombin time was developed essentially as a test which provides us the time that it takes for platelet-poor plasma to clot when you add tissue extract, which is thromboplastin and calcium. This was developed in 1935, and really essentially leverages the extrinsic pathway of the coagulation cascade, which is factor 7, factor 10, which gets activated, and then within the presence of factor 5, activates prothrombin, which is factor 2, to activated prothrombin, and then thrombin, which is 2A, is thrombin generation, which converts fibrinogen into fibrin. So it is responsive to defects in the extrinsic pathway, factor 7, 10, 5, and these are all made in the liver, thus a liver function test. The response is affected, however, by the type of thromboplastin that you use. And so about 15 years ago, the INR was introduced as a way to standardize results across labs for monitoring anticoagulation treatment. So this test was primarily developed to monitor the benefit, how well you're being anticoagulated if you go on warfarin. But we also know because it measures it is dependent on factor 7, 10, 5, and 2, all of which are liver produced, it also serves as a liver function test. So the INR is based on doing a plot of the log prothrombin time with your working thromboplastin in your lab versus an international standard. And then you draw a regression line, and from the regression you get an ISI, which is the slope of this regression line. And the INR is really the prothrombin time of your unknown divided by the prothrombin time of normal to the power ISI. So that's how your lab reports your INR to you. And the INR's greatest value is, of course, in assessing anticoagulant therapy, but it also turns out to be a pretty good liver function test because when you have a defect in factor 5, 10, 2 production, your INR gets prolonged. So INR is prolonged when the liver function fails. It is particularly useful because we use this to determine whether it's time to talk about transplant in the setting of acute liver injury, but also as a prognostic determinant in cirrhosis. It's part of the MELD score, and that's how we use to identify and actually stratify people for transplant listing. Very important to understand that the INR does not correlate with bleeding risk. This is a common misconception because our ability to form a clot depends not only on the procoagulant pathways in our blood, but also on our anticoagulant pathways. So because it is so important that we don't form clots in abnormal manner, there are a lot of mechanisms that both allow us to make clots and also prevent us from making clots. And by balancing them, we have liquid blood circulating in our body. Because if that system failed, we'd all turn into a blood sausage, and that would be a bad thing. So when you're testing the INR, you're taking the blood out and putting it in a test tube and artificially measuring only one limb of the pathway. What happens is that many of the anticoagulant pathways are also produced in the liver. So the anticoagulant factors, protein C, protein S, et cetera, which are important, they're all also made in the liver, and when your liver fails, they decrease just as like the procoagulant factors. So the net balance between the procoagulant and the anticoagulant factors really does not change in liver disease. And most of these patients either have normal thrombin generation, which is a physiologic test, or may even be elevated. So it's a common mistake made particularly by radiologists who will say that they need they will not do a paracentesis for you unless the INR is below a certain level, or they will not exchange a line for you in the hospital unless the INR is below a certain level. Most of that, when you're talking about pure liver disease, is incorrect because INR does not correlate with bleeding risk in liver disease. It's different if the INR is prolonged because you got extensive DIC or other things, but certainly if you have pure liver disease, it does not correlate. The third test we use is the albumin, which is the principal synthetic product of the liver, but the levels in blood reflect both nutrition, absorption, liver synthesis, and potential loss from abnormal sites. So if you have severe nephrotic syndrome, you might have a low albumin, has nothing to do with the liver. Or you have extensive skin burn, or you have a protein-losing enteropathy. The half-life of albumin is 2 to 3 weeks, so it takes a long time for the albumin to change. So given these caveats that as long as you know that you're not losing albumin from different places, the albumin, and you have some handle on nutrition, whether the patient's taking enough, the albumin does tell you about liver function. So liver enzymes, AST, ALT, and alkaline phosphatase tell you about injury, and the bilirubin, albumin, and the INR tell you about liver function. So 3 and 3. So to summarize again, this is just what I told you. The bilirubin tells, particularly conjugated hyperbilirubinemia, tells you there's something going on in the liver. INR changes very rapidly because factor 7 has a very short half-life and is a good marker of the severity of liver injury. Isolated prolongation may, of course, reflect vitamin K deficiency from malnutrition because a lot of those factors are vitamin K-dependent factors. And a common reason to have a prolonged INR without having liver disease are people who have received prolonged antibiotic use, which have wiped out the gut flora. And so we get vitamin K from the gut flora, so that's a common reason why INR could be prolonged. Albumin changes slowly, but may also be affected by malnutrition, renal loss, or loss from skin due to burns or from the intestine. Now, having talked about liver injury and liver function tests, let's now synthesize all of this. So the first step, it really breaks down into sort of a 3-step process. The first step is to identify what kind of enzyme abnormality, liver injury abnormality you have. Is it parenchymal, is it cholestatic, or is it a mixed pattern? Parenchymal means your AST and ALT are the principal things that are abnormal. Cholestatic means your alkaline phosphatase is the principal thing that is abnormal. And mixed is when both are abnormal. So parenchymal could be acute or it could be chronic. Acute is, this is assessed clinically when onset of symptoms and everything is within a relatively short period of time. Patients may or may not be symptomatic. Typically, when you have acute liver injury and acute hepatocellular necrosis going on, the liver enzymes may be more than 10 times the upper limit of normal. So you get high levels of liver enzymes. And depending on how severe it is, the liver function, bilirubin, albumin, INR, may also be impaired. So the common differential diagnoses are the viral hepatitis. And again, hepatitis A, B, C, all of these can cause it. A often will cause an acute rise. We see some acute hepatitis B, especially those of you who live near the coastline and you have a lot of sailors coming in, or you see a lot of migrant populations. Hepatitis E, there's controversy how much hepatitis E really occurs in the United States. Certainly people who've been to Mexico coming back could get hepatitis E. It's quite prevalent over there. And then depending on who you're seeing, there are strange things like Ebola and yellow fever that can also, of course, produce acute liver injury. More commonly, something that you probably will see more often in your practice is the possibility of drug-induced liver injury. And I think my next talk is on drug-induced liver injury, so I'm not going to say a whole lot more about it. Tylenol overdose, ischemia, toxin, exposure to toxins. And there's possibility that there are certain chronic diseases that can actually present acutely with high levels of liver enzyme and acute hepatocellular necrosis. And the ones to remember are hepatitis B, alcoholic hepatitis, autoimmune hepatitis, and Wilson disease. These are particularly important to recognize because there are specific treatments, and certainly for some of these, such as Wilson disease, you got to get them to transplant right away. Otherwise, the patient will die. So if you look at the causes of liver enzyme injury, again, some of the data suggests that compared to what we used to see back in the 70s and 80s, in more recent times, we're seeing in an in-hospital setting more and more people who have hepatic ischemia. So it'd always be sort of, especially in the inpatient setting, you have somebody who comes in with a myocardial event, sepsis, they drop their pressure for a little bit, Next day, you'll see a big bump in their liver enzymes. That's almost certainly hepatic ischemia. And the typical pattern is it goes up quickly, comes down quickly. Tylenol toxicity is also important because it has a very specific treatment, and essentially you should be able to prevent anybody from going further if you catch it early enough. It is a leading cause of acute liver failure in America. So thus, it gets us its own slide in the talk. So something that has changed over the last 15 years is the nature of Tylenol toxicity. It used to be 20 years ago almost invariably a suicide attempt. But now 50% of the cases are therapeutic misadventures because Tylenol is in so many pain medications as in one of the components of pain medications. So patients are already taking their Percocets, they are taking cold remedies, and then they take something else, and they have no idea. They don't feel good. They keep taking more of it. And before they know it, they're throwing up, they're jaundiced. They come in to see you saying, I feel terrible. And it's because they have been chronically taking an excess amount of Tylenol. And this combination of cold remedies and pain medications become a real national problem. And the classic nomogram that we used to use to check the blood level of Tylenol to tell whether something bad is going to happen to the patient no longer applies. So Tylenol gets broken down by this enzyme called CYP2E1 into a toxic product, which is very, very electrophilic and produces injury to the liver. And that's what causes toxicity. The liver's natural protection is glutathione, GSH. So Tylenol toxicity, if you are a chronic drinker, you've revved up your cytochrome P450 system because you induce it. So for the same amount of Tylenol, you generate much more toxic product and much more quickly. So you can get injury from 1 to 2 grams of Tylenol if you're a chronic alcoholic. So be aware of that even if with a small dose, you can get Tylenol toxicity. The other is that if you're severely malnourished because you got some chronic illness, your glutathione stores may be depleted. So even if you generate an amount that a normal person might be able to handle, if you have no glutathione, you have no protection. So with these caveats, remember that we have a low threshold for thinking about Tylenol as a cause of acute hepatocellular injury. If your liver enzymes are over 300, 400, think about these possibilities. So then you confirm your etiology. And of course, this is pretty straightforward. You order the appropriate serologies. For drug-induced injury, you got to get a history. It's reasonable to get a Tylenol level, but don't get fooled if the level is low. And for ischemia, again, the history of shock, sepsis, myocardial infarction, cardiovascular issues. You can get a Doppler ultrasound of the liver to make sure you haven't clotted anything off. For autoimmune disease, you get an anti-nuclear antibody. For Wilson, you get a ceruloplasmin. This is all in your handout, so I won't belabor this. DILI, let me spend a minute about DILI. There is no specific blood test that tells you that you got drug-induced liver injury, so you got to have a fairly low threshold for thinking about DILI, because the people who die from drug-induced liver injury are the people where the drug is not identified as the cause of the liver injury early, and people stay on the drug till the disease becomes quite advanced. So when in doubt, stop those drugs. And the way we assess whether there's causality is typically if you've excluded, if there are no other causes for the liver enzyme elevation, you stop the drug, and very quickly the liver enzymes come down. Typically, we say most likely this was associated due to that drug. The textbook way of doing it is to re-challenge the patient. I never re-challenge patients if they had a severe liver injury. I'm not that brave. So personally, that's where most, I would say 99% of clinicians would stop in terms of causality assessment. And the step 3 is to assess prognosis. Because in any kind of liver injury, at the back of your mind, you're thinking, is this going to get better on its own? Do I need to use a drug treatment? Or do I need to send them to a transplant center because they're not going to get better and they're going to die from their liver disease? And it's always good to have that little exercise at the back of your mind. And so in the setting of acute injury, the things that tell you the patient is in trouble and you need to get the patient to a tertiary care center with a transplant program, is if they have any alteration in mental status, if you have recruitment of additional organs, your kidneys start malfunctioning, you're heading into multi-organ failure. And what really kills these patients at the end is sepsis. So if there's anything that suggests that these things have occurred, the patient is spiraling, and you need to get them out of there to a center with a lot of resources to give the patient their best chance at survival. Because this is a potentially very serious condition, and people die of acute liver injury. If your INR is more than 1.5, that's a very good risk factor that bad things might happen down the road. So again, if your INR is more than 1.5, get them out of there. If you're in a primary care setting, get them to a transplant center if you can. Stop all drugs until you figure out what's going on, except maybe insulin, thyroxine, and beta agonists for asthma. Pretty much your statins, many of the other things, you can stop and then manage on a case by case. If you need to use something for blood pressure, put them on a nitrate drip, things that are relatively safe. Manage blood pressure with alternate agents, refer early, admit the patient. If the INR is more than 1.5, even if they look rosy, put them in the hospital because they are at high risk of getting in trouble. Or if they have inability to maintain hydration or have any mental status changes. So those are some clinical pearls. Moving on to chronic disease, these are where you have minor fluctuations of liver enzymes over a long period of time. Typically, the ALT is less than 10 times. You may have marginal liver enzyme elevation with chronic liver disease. So if you see somebody with liver enzymes in the 60s and 70s, most likely this is some sort of chronic liver disease. Although, in order to get to 500, you have to be at 60 at some point in time to get to 500. So it's always worthwhile checking it one more time relatively soon. If it's all fluctuating in that same zone, it's most likely chronic disease. And viral hepatitis, alcohol, and fatty liver disease, non-alcoholic fatty liver disease, that accounts for 90% of chronic liver enzyme elevation. And then you have a potpourri of some of these other things that are less common: hemochromatosis, autoimmune, Wilson disease, alpha-1, drug-induced liver injury. If you look at abnormal LFTs and their etiology, we see that roughly about a third are easily explained, and most of that is due to viral hepatitis and alcohol. But there's a lot of people where the chronic low-grade liver enzyme elevation is unexplained, and that is largely due to fatty liver disease. And this is a study where they took those type of patients and they did a biopsy on everybody, and they found that about 66% were either fatty liver or actual NASH. And so 2/3 of these patients actually have fatty liver disease, and 1/3 is, again, a miscellaneous potpourri of things. Many people will not tell you they drink, but when you do the biopsy, the truth comes out. So another caveat here is that the normal or minimally abnormal liver enzymes does not mean that the liver disease is minimal. So this again begs the question of what is a normal upper limit of what is a normal ALT? And we need to make a distinction between biologically normal and statistically normal, because the way all the labs set up their normal was based on statistics, not on biology. And so historically, as I told you, people took self-identified normals. They looked at the distribution of ALT and looked at 2 standard deviations above the mean and set a line and said, if it's above this, it's abnormal. That's great for population statistics, but many of these people actually have liver disease. And we now know that this is in data for hepatitis C, that if you look at, regardless of how much inflammation or how much scar tissue, even cirrhosis, a substantial number of people actually have normal liver enzymes. These are the histologic findings in people with hepatitis C and persistently normal liver enzymes. And you can see many of them will have significant liver disease, both in terms of inflammation and fibrosis. Similarly, we published some years ago, now almost more than 10 years ago, about NASH and abnormal liver and normal liver enzymes. And at that time, our lab upper limit of normal used to be about 60. because of the methodology issues I talked about. But you can see that all the way to cirrhosis, we had people with persistently normal liver enzymes who actually had cirrhosis. So normal liver enzyme does not always mean that there is no liver disease. So in the setting of chronic liver disease, we always need to be thinking about risk factors, which is why if somebody, some common questions in primary care medicine that must be asked at every visit: how much alcohol do you consume? And are you engaged in what's called risky drinking behavior? How many people here know what risky drinking behavior actually means? So risky drinking behavior is a specific medical term which identifies a pattern of alcohol consumption that puts you at risk of end organ damage or actually having morbidity or mortality from the alcohol. So whether it is car accidents, whether it is falling down the stairs, having alcoholic withdrawal seizures, and aspirating, whether you get liver disease, pancreatic disease, brain disease, et cetera, risky drinking behavior captures your risk from alcohol consumption for those events. And that is typically if you engage in, if you drink more than 3 drinks at a time, more than 3 times a month, or if you binges more than 5 drinks. So typically in a month, if you have more than 3 times that you drink more than 3 drinks at a time, or if you drink at any one sitting more than 5 drinks, that's binge drinking, those are considered part of risky drinking behavior. So it's a good question to ask and counsel people. So the alcohol is one. Risk factor, at least one time somewhere in your profile of taking care of patients, particularly the first time you see somebody, good to ask questions about even remote history of drug use, and because it tells you about the risk of viral hepatitis. And then if you have risk factors for fatty liver disease, obesity, diabetes, hypertension, dyslipidemia, et cetera, the features of the metabolic syndrome, because they're tightly interlinked. So these are 90% of the causes of chronic liver disease in your population. So at least these few questions are always worth asking in the clinic. To confirm etiology, once you've identified somebody with abnormal liver enzymes, you will once again get the appropriate serology. For fatty liver disease, historically we said absence of other disease, presence of risk factors, and the textbook way of actually identifying whether you got aggressive fatty liver disease is with a liver biopsy. It's not feasible for all patients with abnormal liver enzymes to get a biopsy. We're increasingly moving towards imaging and other ways of assessing non-alcoholic fatty liver disease. So initial assessment includes history. You stop potentially offending drugs, especially if the liver enzymes are on the higher side. Hep B and C serologies should be checked, and you get anti-nuclear antibody. If negative and features of metabolic syndrome are present, also you counsel them to avoid alcohol and engage in some lifestyle modification. If LFTs are still abnormal, and most of these people, when I'm talking about liver enzymes which are marginally elevated, liver function is normal, patient feels otherwise pretty good, you give them a period of time to behave themselves, engage in lifestyle, stop the alcohol, try and get rid of offending drugs, and then if their liver enzymes are still elevated, or if your liver enzymes are more than 10 times the upper limit of normal, or if your bilirubin, if you've got liver function compromise, then these are the 3 sets of things that you can't sit around and wait for things to declare themselves. You got to move forward and do further evaluation. So you can wait if the liver function is normal, patient is asymptomatic, you can track the liver enzymes, and if it's persistently abnormal more than 6 months, something serious is going on. You need to evaluate further. If the bilirubin is, any of the liver functions become abnormal, or the patient is symptomatic, or the liver enzymes are more than 10 times the upper limit of normal, that tells you there's active hepatocellular necrosis going on. Then you need to proceed further and immediately and not wait in those settings. So step 3, that links to assessment of prognosis. So if there's clinically obvious cirrhosis, patients already got ascites, et cetera, or has encephalopathy, you know you have a problem. Or an important question is whether the patient has clinically inapparent cirrhosis. This came up yesterday also in hepatitis C, because the liver will not have symptoms till very late in the disease. So many of these patients may have no symptoms. So some clues that they may be advanced liver disease. is one, if your AST is higher than the ALT, particularly if you've been seeing a patient with chronic liver disease for a period of time, and suddenly there's a flip where instead of the ALT being higher than the AST is now higher than the ALT. And or if you see the platelet count beginning to drift downwards, it's 250, 200, 175, 145. That's a very ominous sign that you got portal hypertension, you're progressing into cirrhosis. Or of course, it's very obvious if they have complications of cirrhosis. So in that setting, to assess prognosis, we use the MELD score, which is based on bilirubin, INR, and creatinine. It gives you a 3-month prognosis of what's going to happen. Low numbers are good, high numbers are bad, and essentially, if the MELD is more than 10, you need to get them to a transplant center. This talks about the AST-ALT value, and once again shows if the AST to ALT is greater than 1, you're either dealing with alcoholic liver disease or you're dealing with cirrhosis. The black bars, the first two, where you have the high, those are alcoholic liver disease or cirrhosis. So what's the role of liver biopsy? You're wondering, I haven't talked about liver biopsy. We actually don't use it that much anymore because we use it when the diagnosis is unclear, and the main use is to diagnose steatohepatitis at this point, to diagnose NASH, because we still don't have a good way of separating fatty liver from NASH. And then sometimes we use it to evaluate if we think someone has autoimmune hepatitis. We use it to assess severity of autoimmune hepatitis, because setting that baseline biopsy is very important, because once you put them on steroids, the decision to take them off steroids, we want to see what the biopsy looks like to make a decision on whether the patient can completely come off steroids or we need to keep them on some low level of therapeutics. So to stage disease, assess prognosis, and to evaluate disease progression. Moving on to cholestatic liver disease, these are diseases where your alkaline phosphatase is the principal abnormality. Once cholestasis becomes more advanced, bilirubin can go up. If you don't have bile, you cannot absorb vitamin K. Remember, it's a fat-soluble vitamin. So if you don't have vitamin K, your prothrombin time will get prolonged and does not necessarily reflect that your liver function is impaired. So just keep those caveats in mind. So these are conditions where alkaline phosphatase is abnormal. Liver enzymes are essentially normal or near normal. And the differential diagnosis is essentially blockage of the biliary tree outside the liver. So pancreatic cancer, sclerosing cholangitis, gallstones, et cetera. Or there is a whole slew of conditions called intrahepatic cholestasis, such as primary biliary cirrhosis, et cetera. And the way we approach this essentially is we get a good history, stop potential drugs that are known to produce cholestatic injury, check anti-mitochondrial antibody, particularly in women. This is a predominantly female-predominant disease. And then we rule out sepsis. Obviously, if there's an obvious cause for intrahepatic cholestasis. In the hospital, sepsis is probably the leading cause for developing cholestatic injury. And then you get an ultrasound. If the ultrasound shows dilated ducts, that means you got mechanical obstruction in your bile passages. You send them to a gastroenterologist for an ERCP. If there's no evidence for biliary obstruction and you have persistent cholestasis, you probably need to get your hepatologist involved to do a liver biopsy. So the etiology of cholestasis, of course, depends on this. So you need to know where the obstruction is, whether it's in the main bile ducts. If it's in the male bile ducts, is it due to a tumor compressing from outside? Is it disease of the biliary tree, like sclerosing cholangitis? Or is it something in the lumen, like gallstones? And then if it's intrahepatic, whether it is an autoimmune disorder or whether it's a drug-induced, and particularly severe drug-induced cholestasis in an older patient can be very serious and essentially can kill the patient. So again, have a low threshold for thinking that this could be due to one of the patient's medications. PBC, PSC are more chronic diseases. PBC, you will have anti-mitochondrial antibody. PSC, when you get an MRCP, you will see that the biliary tree is strictured up. So again, the prognosis depends on severity of organ dysfunction. And that's generally true for all liver disease. The more you get liver failure, the worse your prognosis. And then lastly, the mixed pattern of abnormality where both AST and ALT are abnormal, and as well as the alkaline phosphatase. Bilirubin elevation indicates you got severe injury. It's not part of the mixed picture. And similarly, INR increase tells you that you got severe injury. Mixed picture, as far as you should be concerned, is drug-induced liver injury until proven otherwise. So I keep harping on drug-induced liver injury because it's very common. This is a big public health problem. And when you talk about drug-induced liver injury, it's not just the drugs that we prescribe, but a lot of the over-the-counter, these natural products that these patients take from St. John's wort, et cetera, et cetera. So always ask them about all the other stuff, the herbal stuff that they take from their food store. Because every year there are roughly between 50 and 100 deaths in the US from those type of products, if not more. Those are just the reported ones. Almost certainly this is all drug-related. Sometimes you can have cholestatic viral hepatitis, and then there are some overlap autoimmune disorders. But the drug-induced liver injury is the one you need to be most worried about because you gotta stop the drug right away. So the approach, all told, is look for the offending drug, consider indigenous agents. We just talked about that. Stop all potential offending drugs. Check viral serologies and autoimmune markers. If liver tests do not improve within a few days of stopping drugs, or if hyperbilirubinemia worsens, or the ALT rises more than 10 times the upper limit of normal, refer to a tertiary center right away. Immunocompromised patients may have multiple processes going on, so please consider early referral if the patient is immunocompromised for any reason. So with that, I'm going to stop. Thank you for your attention. Questions? Yeah, this question at the back.
There are times when you have people who are on Coumadin and their INRs are starting to go higher and higher. So they have concomitant alcohol abuse. So my question is about evaluating INR in the setting of people who have venous thromboembolisms. How do you manage their Coumadin if their INR is, sometimes they're autoanticoagulated?
Yeah, well, the autoanticoagulated, as I said, is they're not really anticoagulated. If you do a thrombin generation test, so the best way to assess whether you are appropriately anticoagulated may be to do a thromboelastogram in those patients. But before you start somebody in Coumadin, if you have chronic liver disease, it's important to sort of get an understanding what their INR is based on their liver disease. So if their INR was normal to start with, then if their INR was normal to start with, then you can use Coumadin and use the same parameters that you normally would use, 2.5 as your way to assess treatment, and adjust your Coumadin accordingly. If the INR is abnormal at baseline, that makes it very difficult to assess because your INR is already high, so you don't know how to assess whether you're doing adequate job with your Coumadin. And we deal with that when we get patients with cirrhosis who have portal vein thrombosis that we anticoagulate, and we typically will use Lovenox in that setting if we can. That's the preferred drug. The other advantage is because if you have significant liver disease, there is a risk of bleeding from varices, other things. So even if you use an anticoagulant, you want something that within a few hours the effect will be gone. So you don't want something where the effect will hang around for 3 days and you're then pouring in FFP and flooding their lungs to try and correct their prothrombin time if they do come in with a bleed. Because we're now also seeing, older patients who get put on Coumadin, frequently they get ulcers and they come in with ulcer bleeds. In fact, we've done such a great job with PPIs that we don't see that many ulcer bleeds in general. Most of the ulcer bleeds we see in the hospital are often in the setting of an older patient getting warfarin who gets a peptic ulcer. So again, it becomes a pain in the neck to reverse their anticoagulation because Coumadin has a long half-life. And so in the setting of liver disease, Lovenox is the preferred anticoagulant. Yes, sir.
When do you draw ammonia levels?
We almost never, no self-respecting hepatologist ever checks an ammonia. You look at the patient, because ammonia is affected by constipation. A lot of people don't sort of are aware that muscle actually contributes hugely to the ammonia load. So if you go work out, if you go to your gym and you come back, your ammonia will be high. So there are a lot of things that affect. And if you're sarcopenic, if you've got some muscle wasting, you don't have a buffer for your ammonia in the muscle, your ammonia levels may be higher. So with ammonia, the times we check ammonia is somebody comes in comatose to the emergency room. You think they may have liver disease, but you're not really sure. It's a good way to say, if the ammonia is high, then you say, I'm most likely this is liver disease. So, and Rye syndrome, again, has sort of disappeared. I can't remember the last time we saw a Rye syndrome. So those are the two sort of scenarios where ammonia might be. But we do check ammonia levels when you get acute liver failure, because high ammonia in the context of acute liver failure has been associated with cerebral edema. And we use the ammonia levels to make a decision on hemodialysis, because we aggressively hemodialyze patients if they get hyperammonemia in the setting of acute liver injury, acute liver failure. This is an ICU patient who's got a Tylenol overdose or acute viral hepatitis or has clotted off their hepatic artery. And that really helps protect the brain in that setting. So those are the situations where we get an ammonia. Yes, there's a huge error rate associated with all of those. So that's why I sort of didn't really bring them in. There will be papers coming out in the next year or two from many very rigorously done studies showing that their sensitivity and specificity are highly overrated. You are probably better off with either a fibroscan or by doing something very simple like looking at a AST to platelet ratio. None of these outperform a FIB4 or an APRI. So personally, we tend to use FIB4s and APRIs and fibroscans rather than either the hepatitis C or the NASH FibroSure test. Yes, ma'am.
What kind of elevations of alk do you worry about in PBC in middle-aged women?
If it's more than 1.5 times the upper limit of normal, certainly that gets our attention. The specificity of an alk phos between 100 and 150 is sort of, it's all over the map. But as you get above 150, it's more important. For PBC, now we know also that once you institute treatment, one of the response parameters is what happens to the alkaline phosphatase. So if you drop your alkaline phosphatase below 150, those people have almost a negligible risk of liver-related mortality. So it is now becoming one of the endpoints for therapeutics. So if you know that if you can drive the alkaline phosphatase down below 150, then that may be, that's therapeutic success in many ways. And that's actually being used by, under consideration by FDA right now to change for new drugs for PBC that are being developed to actually use that as the threshold for measuring therapeutic success. Yes, sir. Very, very uncommonly, if you have persistently elevated alkaline phosphatase and you've done a very extensive workup and you still have no clue what's going on, and you're trying to avoid doing a liver biopsy, you're at the last step before doing a liver biopsy, you might consider fractionating it, to try and, if it comes back intestinal, then you save the patient a liver biopsy. But some people would also use a GGT in that setting. And if the GGT and the alkaline phosphatase both are elevated, then again, it points you towards the liver. So those would be the two settings. Any other questions? Yes?
Who should be screened for hemochromatosis, and what's the best test? It seems like whenever we see it, the person already has severe disease or...
So, well, first of all, if there's a family history of hemochromatosis, if there is any chronic liver enzyme elevation, part of that initial panel of tests that you get is a iron saturation, which is a transferrin saturation. And so if the transferrin saturation is elevated, then you get the gene test for hemochromatosis. So there is no current recommendation to go out and screen the entire population. You know, about 20 years ago, there was a lot of hoopla that this was the most common genetic disorder out there. The entire population needs to be screened. Since then, it's been found that even though the gene, especially the heterozygote state, may be very common, the penetration of the disease itself is actually much less. So people have backed away from saying the whole population needs to be screened. So currently, if there is evidence of chronic liver enzyme elevation, or if there's a family history, then you get an iron saturation. If the iron saturation is over 50%, that's a pretty good marker that you have some iron overload. Ferritin can mislead you in this setting. Some people use ferritin as well, but ferritin is an acute phase reactant. And given that 2/3 of our population are obese or overweight and are systemically inflamed, ferritin can often be high. So ferritin, you'll get a lot of false positives with your ferritin. So the transferrin saturation is probably a little better way of looking at it. And if the transferrin saturation is over 50%, get the HFE gene test. Questions? Okay. Well, thank you.